All right. Well, welcome everybody. We'll go ahead and kick off here. I think folks are still joining. Welcome. So here we're going to talk about comm strategies for COVID outbreaks today. For those of you that are new, it's nice to see you. A lot of familiar faces as well, which is great. So this is one we did pretty quickly, given the situation on the ground for a lot of folks has changed pretty rapidly in the last week. So we thought it would be useful to share some first takes on best practices and experiences that we've had helping some of our customers sort of in the mud on some of these outbreaks more recently. So it should be a good lot to cover today. So a little bit of housekeeping as usual. There's a chat box and questions. Feel free as we go along to put questions in there. I think what we'll try this time is at the end of each section, there's 3 parts to this. We'll take a break and answer any questions that come up. Also, would love feedback if there's any other topics or areas that you'd like to share thoughts on. That's always really helpful. We're all sort of learning together as we go, so it's always good to put these together. So for those of you that are new and don't know who I am and who we are, my name is Mike Reich. I'm the CEO of DataContours. We've been doing work within the healthcare space for about 10 years, doing analytics and modeling and population health data. And most recently, within the last 3 months, we've launched our COVID dashboard, impact dashboard, which has turned out to be really helpful for folks as they're monitoring for outbreaks and then working to respond to them. So a lot of what we'll talk about today is based on both the data and analysis, but also the experiences we've had. So what we're going to try and cover is, first off, just what have we learned since March, basically. First time we all went through this, this was brand new. Nobody really knew about a lot of the basics of the disease and how it progresses and what the implications are for public policy. So a lot better sense 3 months later. There's been a lot of new research, a lot of things have crystallized. And so I'll share some observations about what's changed and what the implications might be. We got some thoughts on communications planning and best practices. There have been some communities that have had to mobilize their incident commands and be responsive. And so I think there's some good best practices and lessons learned that have emerged from that. Walk through an example of how we might apply some of those lessons and what some of the messaging might look like. And then, as usual, happy to answer any questions that y'all have. So we'll start off here, go through what we learned. Again, if you've got questions, feel free to put them in the chat. This is going to be pretty detail heavy, but happy to come back if there's anything that we want to dive into. So first off, what have we learned about infections? So as many of you know, the question around infection to tests is a complicated one. We're not testing enough, which we'll talk about a little bit more. But this ratio of 10 tests or 10 infections to 1 positive test has held up pretty consistently. So that's a good rule of thumb. If you're seeing some number of tests, positive tests within your community, you can multiply it by 10 and you can get a sense of what the actual number of infections are. So the downside of this number, and because it's not gotten dramatically lower, is that by the time a test shows up, it's largely likely that an outbreak is already underway. And so that's one of the challenges here, is until we dramatically increase testing beyond the sort of gradual increases that we've seen, we're still way behind the curve and catching these things early. One of the things that has been interesting and emerged is that infection rates are different amongst different populations. So there's been some good research showing that at least to date, infection rates among older people are higher than what we would see within the younger population. It's unclear why, whether this is because they're more susceptible to infections, or if it's just because they're in environments like skilled nursing facilities and elder care facilities where they're more likely to be exposed to the virus. So it is something that we'll bear watching, especially over the next couple of weeks, if we see increase of rates of infections amongst younger folks with the protests, and so kind of what the emerging dynamic there looks like, or if it's really just a characteristic of the virus that that folks who are older and at higher risk anyway are also more likely to become infected. So one of the interesting things that I think has really also crystallized in the last few weeks, weather really is not playing much of a factor in infection rates at the community level. There was a thought back in March or April that potentially, like the flu, we would see a seasonality with COVID, and we would see a consistent region-wide, countrywide drop-off in infection rates over the summer because something about the environment, either the heat or folks being outdoors more, lowered the overall infection rate. And unfortunately, we've really not seen that. So it's not clear why there is that effect for flu, but not for COVID. But we're seeing infection rates go back up again. And so, interestingly, is starting to emerge kind of an inverse relationship where most of the newer infections have been in the South and Southwest. And so one question has been, actually is weather driving that, and that it's driving people indoors into air conditioning, which we do know increases the spread. So we'll be keeping an eye on that to see what research emerges. So another point that I think is pretty clear: masks work. And so the more people who are wearing masks, the lower the overall infection rate within a community is. Some interesting stuff over the last couple of weeks. There was a couple of good case studies that came out of Asia showing that when they actually went in and traced the clusters, there are about 20% of people causing 80% of infections. This is both good news and bad news. It's good news in that it's such a low number, but it's bad news in that nobody really knows why. Is it because those people were just, they saw 80% more people than everybody else? Were they in environments that led to these spreads, or are they sort of the super spreaders who somehow put out more of the virus than others, therefore infect more people? And then the last point around infections is, I think large groups are accounting for a majority of outbreaks that we're seeing. So there is community spread, but many of the bigger numbers, especially to start with, are groups over 15 people. And so there is certainly a significant source of the increases is from these large group gatherings. And I think that just raises the risk of some of the relaxing of social distancing measures or adherence to social distancing, because those large groups do tend to be the place that people get infected. So the key takeaway: infection rate is dependent on a lot of different things. It's also highly variable, and there's still a significant amount of unknowns. So there's an interesting chart that I saw. I thought was worth sharing. It's kind of a regional breakdown in the U.S. of overall infection rates. Actually, positive cases, so tests. And so you can see there's a big spike in the Northeast, New York, New Jersey, Connecticut, mainly in April, and then a similar spike in the Midwest, though about a third of the volume. And this was, Detroit, Michigan, Illinois, Chicago. But both of them have seen fall-offs in the virus. And then you had the South and the West, which really didn't see the same spikes in March and April, but have seen significant increases recently. And so one of the things that's emerged is the red line that's through there. It looks like generally healthcare capacity fits at about the 125 cases per million people. So once we get above that line, just as a rule of thumb, we start to see utilization approaching 100%. So the takeaway from this is, we still have room, even though there are places like Arizona and Texas that are seeing increase in positive tests and increase in hospitalization rates. They're not quite at 100%, or they're getting close. But when we start to get to that 125, 150 test line, then generally we can start to be concerned. And the takeaway with New York is we're about 3 times that number. And so we would be looking at a really bad outbreak in Arizona or Texas would be about 3 times what it is today. All right, so some thoughts on testing. So that 10-to-1 ratio, kind of leaning back into testing, is about 10% of what the ideal capacity would look like. We'd want to see about 5 million tests per day, ideally. And right now, I think the line is around 500,000 per day. So the challenge with this is we're not testing enough people to really test and trace effectively. And obviously, there's kind of regional and state variations in this, but I don't think really anywhere within the United States is at the level of testing that public health experts would like to see. And so that'll continue being a challenge, both because we don't really know the extent of the spread within a community, but also as infection rates tick up, if you can't test them, you can't trace them. We would expect, and I think the takeaway in all of this is community spread is already happening pretty much everywhere. It's just a matter of at what rate. And so it does require a different set of policy approaches and what's practical versus where we were in March. So we'll talk about it a little bit later. About 50%, probably less than 50%, can be traced to workplace outbreaks. And so again, most of the infections, the majority of infections are community spread. It's not the places like meat packing plants where the majority of outbreaks are coming from. I know there's been a couple of different, there's sort of conflicting narratives in the media around this, but I think the science is fairly clear, or at least the research to date. And another interesting note. So certainly the worst case is we see an increasing testing and increasing positivity rate. So we're testing more, and more of the tests that we do come back positive. But increasing testing and a stable positivity rate is also not great. I mean, it's not as bad as increasing positivity rate, but a stable positivity rate still means that we're not getting ahead of the virus, and that spread, the reproduction rate is above 1, or likely to be above 1. So what we're really looking for, and I think what you've seen in New York, which is probably the best place in the country right now, is an increasing test rate and a decreasing positivity rate. And so that's what we would really want to see across all communities. Big takeaway: testing still continues to be important. And we're very far away from the level of testing that we need to be doing to really get a hold on what's happening in communities. All right, so what have we learned about hospitalizations? Reinforcing the point, hospitalizations are strongly correlated with average population age. The older the population within a community, likely the higher burden on the healthcare system, because folks over the age of 50 have such a dramatically higher need for care than folks under the age of 50. And that has been pretty consistently found over the last 3 or 4 months. But interestingly, it's not totally clear why hospitalization rates have generally been lower than initially expected. So some of the early numbers back in March were like 30 to 40% of folks over the age of 60 would need hospitalization. And then, almost half of them would need some sort of ICU support or ventilation. Turns out it's actually been a lot lower, and it's not totally clear why, because the severity of the virus is not less than we thought it was. It turns out a lot of folks who otherwise would seek out hospital care are not, either because they're in skilled nursing facilities, which are offering some level of that care, or people just are avoiding hospitals because they don't want to risk going to a hospital. This is a really interesting public health challenge, because I think from what we've seen, in some places, the messaging around seeking out care has maybe been more effective than we wanted it to be, to the point that people who ought to be seeking out care are not. And so unfortunately, the risk is that this drives overall mortality higher within a community than it otherwise be, because people aren't seeking out the care that they need. And if you don't go early on and you end up needing ventilation, or you should be on a ventilator, but you're at home, the odds of you then being able to get care at that point, especially if you're elderly or living alone, are a lot lower. This will be really interesting to look at on a regional level. And after all this is done, being able to explore some of the reasons behind this, because I think there's some really interesting public health learnings and challenges that sort of this raises around messaging and how to thread the needle between ensuring people get care, but also not overwhelming capacity. So, the general level of thumb, I think going forward, is we probably would see 2 to 4x some of the original estimates from March in number of infections to put capacity burden on health systems. So there's a lot more capacity than we thought back when some of the original modeling was done. And lastly, around mortality, so the infection fatality rate is consistently around 1%. I think that, there's variations across the globe, but around 1%, which puts it at about 10 times the fatality rate for the flu. Based on total mortality figures, we would assume, and I think what I've seen from some of the research looking at overall deaths within a community, the positive mortality, COVID positive mortality numbers are probably underdoing it by about half. So there's another way of saying it, is there's 50% of people who are dying outside of a hospital where they've been tested. And there could be a lot of reasons for this, but one of the big ones that pops out is people who are dying at home because they're not seeking out care. There I think is an ongoing challenge here. One, we probably won't know the true number of people who died because of this until a year or two after, and all of these total mortality studies are done. But also, it raises the specter that there's a pretty big pool of people who are feeling significant effects of this who are not currently in the healthcare system. And so, again, if we are successful in getting them back in the healthcare system, some of the assumptions we make about capacity are likely to be wrong. Okay, so what have we learned about the disease progression? And this is really thinking about the timeline, because as you know, there's somewhere between 18 to 25 days between initial infection and resolution, depending on the model that you're looking at. And I think what's become clear, interestingly, at the community level, this turns out to maybe be too quick by 2 to 3 weeks. We've seen these lagging indicators around hospitalization, ICU escalation, mortality, lagging longer than we would expect. And I think, especially as we were in late May, early June, there was a lot of conversation around, okay, increasing infection rates or increasing positive test rates, but not seeing the equivalent increase in hospitalizations. And that's because it was a week or two later than people were expecting. So now we're starting to really see the increase in Arizona and Texas, for example, in hospitalizations much longer than we expected to see, or much longer than we saw back in late March and early April. So it could be a couple of reasons for this. treatment might be better. Folks may not be as sensitive to infections, so they may be waiting longer to go to hospitals. Maybe because, again, they're afraid of getting into a healthcare system. The implications, though, I think in monitoring for outbreaks are, right now, it's really unclear when and whether that spike in healthcare utilization will happen, because it's much less predictable on a region by region basis than it was back in March. This also could be because infections are happening amongst younger people, and they don't need hospitalization at nearly the rate that older people do. So there's some important population dynamics and characteristics to start exploring when we see this. This will continue to change because we'll start to see increasing availability of treatments that will likely drop the need for ICU escalations or ventilation, and certainly will drop the amount of time that those folks are on or receiving care. So this disease progression and what the implications are as we look at milestones for monitoring an outbreak is probably the most fluid of everything right now. A couple of other observations, and then we'll take a break for a couple questions. Generally, and you'll see in some of the charts we use here, focus on a 7-day moving average. There's a lot of daily noise in reporting. There's this weekend effect, which is pretty well known now. Saturday and Sunday have 50% the reported levels that Monday, Tuesday do because folks are out of the office, they're taking a weekend. Increasingly, I think most places are showing a moving average of some sort, and we certainly recommend folks pay attention to that rather than any sort of day-to-day spike. Increasingly, and this is where a lot of our work comes in, the state level numbers are not particularly useful for most folks. Most states are a combination of urban and rural areas, cities, and small, medium size, and large cities. Really getting to some of the regional multi-county effects is important. I know here in Oregon, finally made the change to treating the 3 counties, it really should be 4, but one's in a different state, around Portland as a single unit. Was sort of the big thing that happened this week, and happened because realizing that some of the other counties were moving too quickly and reintroducing infections back into the counties that hadn't moved as quickly. So beginning to look underneath the state level numbers and start to think about, communities and populations, I think is a really important nuance and way of analyzing the data that folks are beginning to see. And thinking more broadly, it's not just your city boundaries, but rather all the city plus all the communities around it where infections may be. Because we're kind of in it for the long game. And then the last thought, the seroprevalence studies that have come out have been pretty consistent globally, showing 5 to 10% of the population has antibodies, which means they've been infected. It's an open question how soon they will be able to be infected, whether it's lifelong immunity or it's something more like the cold. That's about 6 months. But regardless, we're still pretty far away from what we need for herd immunity, which is 60 to 70%. Unfortunately, there's even New York, I think, is the highest estimates I've seen is 20% in New York. So we're a very far along away from having community level herd immunity. Okay, so let's take a pause for questions here. Yeah, we'll share the slides afterwards. If you're new to this, you'll get an email with a recording. We'll also follow up with slides, and that'll include the sources we use for the data that's in here as well. Okay, so thinking about communication principles. As we've looked at this, and one of the things we most enjoy about our work is this nexus between data and action. And this is one of those times where it's been really interesting to see this come into play. I think the key takeaway, from the last 3 or 4 months around data and information and decision-making is people want information. And unfortunately, if public officials don't provide it, somebody else will. So there's been, a range of responses to how transparent should we be and how should we communicate with folks, from not at all to, daily transparency and pretty good updates. So, I think from our perspective, given the internet and social media, it's a guarantee that if public officials aren't doing it, somebody else will. And there's a number of challenges, obviously, that come with that. So we certainly, and you'll see throughout this, encourage public officials to lean into communication, to see it as an opportunity, and really, a duty to the community that, if they do well, makes everybody's life easier. So there's some principles that make this actionable. And the first set kind of falls under this early and often category. So, the biggest challenge with data and analysis and communication here is uncertainty. There are a lot of unknowns, and there's some more knowns, but we're seeing more unknowns as well. So frequent communication and doing it early and getting ahead of the game helps fill in the information gap and reduces erroneous information and allows you to sort of set the narrative around those uncertainties. I think that the second thing is you're communicating is people really want a narrative. There's one of the things we've seen a lot of is folks just putting out numbers without really contextualizing it for people. And again, this is a case of if public officials don't provide it, someone will. And largely public officials are in the position of having the most information and really the sort of the narrative. And so there's a real opportunity. And this, unfortunately, I think a lot of this is kind of a fear of bad news in some ways, or not really knowing how to communicate all the uncertainty and all that goes along with this. But fundamentally, people do want to know if things are getting worse. I mean, that's from a planning perspective. Most people are much more aware of the downside risks. And unfortunately, the downside risks become a lot greater for people in an absence of information. And then the last thought here is imperfect data is better than no data. I think this is a great example of, perfect being the enemy of the good, in that, it's never going to be bulletproof. And sharing imperfect data and acknowledging and being explicit about what the imperfections are is much better than deciding not to share it. And we'll talk about some nuance within that, obviously, because it is important to recognize there are differing levels of sophistication around data and education and ability to interpret some of this stuff. So, absolutely, I think there's some narrative that goes along with it, but nature abhors a vacuum, and so if it's not out there, it's going to get out there from somewhere, and usually it's a lot harder to change the narrative once it's been established. Second idea here is kind of consistent themes, different details. On that point of different audiences need different information. One of the most damaging things we've seen from a data and communications perspective is decision makers communicating one set of facts to people, but using a different set of facts in their own internal discussions. And it's not a matter of if, when that makes it out into the public, there's a huge credibility problem that creates. So what we try to share with folks is, and encourage folks is, think about this in terms of consistent themes with different levels of details that you provide to different audiences. So tailor the messaging that you're giving for what their capacities for, or not just capacity, but what their needs are. What are the questions that they really want to know? And the public usually wants to know different set of things than decision makers need to know in order to make informed decisions about public policy. So recognizing that nuance can be really helpful. But most importantly, being consistent. So the overall message, are things getting worse? Are they getting better? Has to be the same whether you're talking to people inside the building or outside the building. And figuring out how to do that is the art. So the last way to think about this might be, what are the questions that your audience has that are explicit and implicit? And generally most people want to know the what and the why, where we are and why does it matter. Decision makers need to know a whole bunch more around probabilities, downside risks, what's the likelihood of any particular scenario, and often that's too much for the public, because it doesn't focus on what they need to know, which is the what and the why. So the last thought, and this is maybe the most challenging for folks, is embracing uncertainty and leaning into this. So one of our big takeaways is numbers in of themselves are pretty useless to people. It doesn't matter who you are. A number without the context for how it makes sense, is it good, is it bad, is really of no use to people. So again, it's back to that narrative point of making sure to wrap any of the metrics or the data in an explanation of what does it mean, what are the implications of this. So tell people what the numbers mean, not what they are. And again, if you just put the numbers out there and leave the interpretation unsaid, somebody else is going to do it. And there's no guarantee that they have the background or the expertise to do that accurately. So one way of dealing with uncertainty is, rather than kind of focusing on the numbers, instead what you're trying to articulate is goals and update on progress towards those goals, or milestones, however you want to frame it, right? But it's like, here's what we're watching, here's where we're going, and here's how far we are. And so a good rule of thumb is be explicit about the criteria you are using to make decisions. And it's okay to change those criteria, but just be clear when you are. I think one of the big uncertainties that people struggle with is, not being sure of what it is they're trying to make decisions based on. And we'll talk about what some rules of thumb might be for what you want to look at. And so instead of communicating that, they just communicate nothing. And people are left wondering, what is the next thing that's going to trigger an action that I need to be prepared for? And that we've seen causes a lot of uncertainty and just a lot of work for everybody, because questions are coming in, and nobody has a great answer for it. So next thought here, acknowledge changes. Things change, data comes in, data changes, decisions need to be updated. I think that's just the rule of the game, and I think it's okay at this point to acknowledge it, and acknowledge it promptly. I don't think anybody expects a statement from 2 months ago to be unchanged today. And so acknowledging and creating a system where those changes can be communicated clearly is really important. And then the last thought, this is also probably one of the hardest, is criticism is inevitable, so you might as well accept and embrace it. So there are many folks who know a lot more than we do about this, and we get criticism from them all the time. There's a lot of folks who are just learning and want to share their thoughts, some of it good, some of it bad, and that's just a part of the process. So we really encourage folks to acknowledge the imperfections in the data that they have in the decisions they're making, and use that criticism that comes in as valuable feedback on ways to address what they're doing. So it's much easier to just accept it than try and avoid the criticism, because that you're never gonna be able to get away from it, unfortunately. We'll talk through, last part of this is actually kind of a case study, walk through some examples of how we might communicate this and what an actual comms plan might look like for an outbreak. But looks like there were a couple of questions. So can you repeat the information on the number 1 slide? We can. Let's race through this, and if we have time at the end, we'll come back to those points and we can talk through them again for sure. Okay, so what might a comm strategy look like? So the scenario we'll talk through is a medium-sized, semi-urban region in the Northwest. Positive tests peaked in March. Strong social distancing, business shutdowns, and good population adherence. So the peak the number of infections started going down. There's been a couple of small outbreaks in April and May. Lowest level in late May, about a quarter of what it was in the peak in March. However, we've seen an increasing infection rate since June 1. And hospitalization, ED visits are lagging. So it's unclear if they're increasing more slowly, why they're increasing more slowly than new infections. So some data, new positive tests and new deaths as it looks June 1. Again, you can see sort of the peak in late March, early April, slow decrease, a couple of little outbreaks in May, and then we started to see this increase in early June. Interestingly, deaths are at their lowest. So we're seeing the increase and maybe a plateau in testing, but deaths are sporadic and low, and average about one, less than one per day. So an interesting and probably familiar situation for a lot of folks. So what would we recommend? Taking this in a kind of a timeline approach. So you're looking at these numbers on day one. What do you do for the next couple of days? So the key question in days 1 through 4, after you start to see an outbreak, is this a blip or a trend? So the key things at this point are learn more. You have a whole bunch of unknowns about what this outbreak might look like, how it's going to evolve, and what the implications from a policy perspective will be. So this is really the key point of identifying your measures and starting to get more data. And we'll talk about what those might be specifically. At this point, you can totally ignore hospitalizations and deaths. They're meaningless because they're going to be trailing 2 to 3 to 4 weeks, depending on what actually happens. So they're just distracting at this point. And a lot of folks want to come back to hospitalizations and deaths are not increasing at the same level of infections, and that really doesn't matter at this point. So as you're already starting, I'm sure, to get incoming questions, go ahead and be responsive to them. We'll talk about what some talking points might be. But really, this is about laying the groundwork for if this turns out to be an increase in an outbreak rather than just a plateau, what's the comms plan, and what do we need to start being affirmative about communicating to the community? So based on those charts, what else would you want to know? There's really 4, probably more, but these are the ones that came to mind. 4 things you would want to know that are often harder to get, so they take some digging. So positivity rate. So if you're in a state level data is pretty good. County level data is also increasing. It's getting better around positivity rate, but this can be really challenging because tests are being done at different places. They're being done in the private sector. Getting good aggregate numbers for positivity rate is really challenging, but is probably the most important thing, because if this number is stable or increasing, that is a really strong indication that you're going to be looking at a long-term community spread rather than maybe a single spike caused by a facility. If it's falling, that's even better, because this might be due just to increased testing capacity. So we're testing more, we're catching more cases, but the actual rate of spread within the community is going down. So this is going to be a key point, maybe the biggest point that you want to communicate out to folks going forward is, what is the positivity rate doing? The next thing that's really important to understand is, what's the average age of new infections? So are you seeing infections and positive tests coming in from folks who are over the age of 50 or 60 or under the age of 50 or 60? This has dramatic implications for potential hospital utilization and whether you need to be exploring plans for expanding capacity. So if again, there's about a 10x increase in care utilization if you're over the age of 50 or 60. And obviously with vulnerable populations or populations with comorbidities, that number is going to be high as well. So as you're planning and as you're looking forward, the average age of those new infections is going to be incredibly important. If it's lower, if it's under 50, you're not likely going to see a crunch on hospital resources unless something about the disease changes dramatically. One of the other interesting numbers is the percentage of cases where the source can be traced, and this is going to come from your public health departments. This will be really useful. The higher this number is, the more confidence we have that we're tracking the sources of these outbreaks and it's not widespread community infections. If it's lower, and I think in Oregon right now, for example, it's 30 to 40% of new positive tests. They can't determine where that infection came from, whether because it's a lack of tracers who can contact these folks in a timely manner, or people just don't know it came from a doorknob in a restaurant. It's unclear, but that number being so high is not a great indication that we have any sort of ability to control the spread of the virus. The last thing, generally understanding more about population characteristics. There's a lot to be done as more places are releasing data at the zip code level. There's a lot to be done around analyzing risk based on some of those vulnerable population characteristics. In particular, being able to look at the rate of comorbidities, and there's been a lot of talk about minority communities, and just to be totally clear with everybody, there's nothing about being in a minority community that makes you more susceptible to the virus or its impacts. It's really the comorbidities that exist with those communities, and unfortunately, if you're in a minority community, you're much more likely to have other heart conditions or be obese or have high blood pressure than everybody else. So as much as you can, from a population health perspective, understanding the future risk based on where those outbreaks are occurring within your communities can give you a lot of forward-looking information about potential burden on the healthcare system that you would miss if you looked at it just from an aggregate level. So some key talking points you could use, and we've split this up into what's kind of internal and might you tailor for your leadership versus what would you talk about with public and outside stakeholders. And again, we're going to try and use those principles that we talked about, consistent broad level messaging and narrative, but the details may be different. So, at this point, early in the outbreak, we would probably frame it, for decision makers as, look, we're starting to see an increase in new positive tests. It's unclear whether this is a short-term increase or long-term change. Totally own that uncertainty, because that's a really important thing to acknowledge at this point. The options that it's likely to be are, and the things that we should be preparing for internally as an organization. This could be a new plateau. So we've just hit a new level of infection within the community. It's probably not going to increase. And this is because of relaxed social distancing. It could be a small outbreak that doesn't continue. So we see a peak and then it's going to come back down and revert to the long-term mean. Or it could be the beginning of a large community outbreak, in which case we want to think about what we would do. So it's unclear, though, at this point, if there are or will be impacts on healthcare or other resources. So if we were going to turn that around and talk to folks in the public, we would again want to acknowledge we're closely monitoring the increase in the number of positive tests, acknowledge that it's unclear whether this is a long-term or short-term increase, and emphasize you're preparing for either scenario. And then this is the key point. This is starting to set those benchmarks and communicate progress towards them. So what's the next decision point? We'll be looking to see if the positivity rates in the community increase by 1 to 2% over the next 3 to 5 days. If that happens, we will begin to explore additional measures, because that is going to kick us over the point where we would be concerned about the outbreak spreading beyond our ability to control. Okay, so fast forward to June 10th. We're some number of days later. The data's changed a little bit. We actually saw a little bit of a dip, and now it's back on the rise. So it's kind of that day-to-day variability. Interestingly enough, the mortality rate, reported deaths, is also starting to increase. So we're starting to see those tailing indicators catch up to what the positivity rate. Here is about a 2-week lag from late May into beginning, mid-June. Hospitalizations are anecdotally increasing as well. So how might you begin to analyze where you are here. So in days 5 through 8, this is really now a question of how severe is it. We know it's continuing. So is it going to be continuing at a significant rate or a more manageable rate? And key thing is starting to think about the potential impacts. So I think as most people have realized, you're not planning for what you're doing today. You're planning for what you're going to have to do in 3 to 4 weeks, because that's already baked in. The people who get infected today are going to be in the hospital in 2 to 3 weeks, and they're going to either get better or they're going to die in 4 to 5 weeks. That question of who is affected, what's the age of the people who are being infected, really key. If it's under 50, you have a much different scenario than it's largely folks over 50. And then, this most important question, can we trace the source? If not, then the high side risk of uncontrolled spread increases significantly. So we would be much more concerned that this exceeds our projections rather than is below our projections going forward. So some key talking points you might use at this point in this situation internally. Acknowledge both test infection rates and positivity rates are increasing. This is the increasing likelihood of sustained community spread. Not yet seeing the lagging indicators, hospitalizations increase at the same level that tests are increasing. They are increasing, but not at the same level. And then start to talk about odds and probabilities, because this, for decision makers, the thing that they're trying to weigh is if we do this, what's the cost benefit ratio for each of the different things that they're going to have to consider. And so being able to supply some probabilities around medium worst case scenario can be really helpful. So we see an increasing odds of that medium worst case based on the infection rate, and say the average age is over 50. One of the key points here, a lot of these communities are coming at it having already implemented shutdowns and maybe just beginning to open things up. And so that increases the odds of the high side risk, because you're already doing almost as much as you can within the community to stop the spread. Key point, likely to require some change in policy approach in the next week if this continues. So when you talk to the public stakeholders, you may frame this a little bit differently. Consistent with the big messages, we continue to see an increase in positive rates. Come back to the threshold that you set in the last week, which is it's now exceeded that 1 to 2% positivity that we talked about. So we're going to continue to monitor whether this increases or whether this is a new plateau. Now that we've exceeded 1 to 2% positivity, here's our next milestone, which is whether hospital capacity is decreasing. If we start to see hospital capacity decrease, then we're going to need to work with the community to consider additional measures. So a week later, June 17th, this is, we're now 400 times where it was, 400% above where it was in late May. So we're off to the races, and still seeing an increase in deaths, but not at the same level as we're seeing increase in cases. But again, probably wouldn't expect to for another couple of weeks. So what do we do in this period? So thinking about, again, what's our response going to be? What's the intervention? What's the public policy approach to this? At this point, just global or within the country, targeted interventions are likely to be most successful. So the need for a broad community-based shutdown is probably past, given we know a lot more about the characteristics of the virus and we have larger capacity to test. And so it's, I think for most places, looking at specific populations or communities and tailoring your interventions for those specific on the ground characteristics is going to be a lot more effective. Key thing in this point, you got to act quickly. So any delay is going to dramatically increase cases and deaths within 2 to 4 weeks. I mean, one of the studies we saw in New York was, had they implemented their shutdown even a week later, they would have saved something like 30,000 infections. So every day, because we're looking at exponential growth, has a huge downstream impact. So it is important to act quickly and that's why you want to be prepared 2 weeks before this with your scenarios and what your potential interventions are going to be. And then with the public, if you start to sound the alarm, moving to daily updates and increased transparency, leaning into the increased demand for information is really important. Because again, if you don't, somebody else is. So what you might talk about with internal leadership at this point would be, continuing to see this increasing likelihood of sustained community spread. We're probably talking, weeks to months rather than days at this point. Need to increase adherence to existing policies. So our first step is, can we do what we're doing better? And can we help the community understand why it's important to do these things? And primarily adjusting and limiting large group exposures and masks are the two things that seem to work the best in the short term. So those would be things to consider. You're starting to see lagging indicators catch up, and we would expect that to increase, start to manage expectations around hospitalization and deaths, especially if you have an older population, which is showing up. And again, increasing odds of a medium worst case scenario. And then, at this point, the modeling is good enough that you can start to provide some of the cost benefits. So if we don't do anything today, we're likely to see 2,000 additional deaths in the next 6 to 9 months. Key points like that can be really, really effective in helping people understand in a quantifiable, tangible way what the effects of their decisions are today. As you're talking with the public, again, being consistent with that messaging, hospital rates and deaths are increasing. Come back to your benchmarks. So we are seeing that thing that we were looking at that's now exceeded where we wanted it to be. Be clear about what it is you'll be doing. So we're going to be requiring face masks and living gatherings. And then going forward, what are the next set of milestones? We can consider relaxing restrictions if we see the infection rate fall below 1% for 5 or more days, or we see significant hospital usage decline. So, another example of being regular and consistent about what it is you're looking for and how you will be making your decisions. Okay, so going forward, at this point, it really is dependent on the track of the outbreak. So you can kind of rinse and repeat, and you can almost, follow this as a 2 or 3 week cycle where you put out an intervention and then you take a step back because you want to assess the situation again. Are you going to start to see those key metrics go up or down? Are things improving, holding, or getting worse? You want to maintain increased communication. We've seen across the board a much better response within the community and a lot less work for folks when they just plan on doing daily or very, very frequent updates, hopefully in person with somebody. And then maintain that consistency in reporting. At this point, especially when things are starting to get heated, changing the goalposts can be really challenging for folks, and definitely adjust if you have to, but make sure it's clear and transparent why those metrics are changing. Okay, so a couple of quick questions that we commonly get that we'll touch on, and then we can do some questions and wrap up here. So should we shut down? Again, probably not. Again, I talked a little bit about this, but targeted interventions are likely to be more effective based on the infection characteristics. So focusing on mask usage and focusing on large group gatherings and tailoring, for a specific scenario. So you're seeing, for example, the average age of your infections is 35, and it's within a part of the city that has a high concentration of restaurants and bars. You may decide that your first step is limiting the amount of people or the hours that those restaurants and bars operate in as a way to restrict group size, or requiring masks at all times within those places. That's likely going to be more effective for that particular group of infected people than shutting down the entire city, where you start to lose adherence. So yeah, first goal should always be improve adherence to existing limits. So how can you make what you're doing more effective rather than imposing new ones? So we get this a lot. I mean, generally, what information should we share with the public? Again, be transparent, be pragmatic. It's okay. I think at this point, from a data viz standpoint, everybody's seen a model projection at this point or read an article about it. So I think there's a lot of education and there's a lot of knowledge and acceptance of that out there. But however, you do want to be careful and pragmatic about what it is you're sharing. So you don't need to share everything. And we think more important than any specific detail is this idea of consistency and being clear about what measures are being used to make decisions. So the question about projections and models, I totally acknowledge these can actually do more harm than good if you're sharing model projections without the context of how they're being used. And some of the worst press we've seen has come from really terrible model projections that internally were never being considered anyway. But they got out to the press, and because there wasn't that narrative and there wasn't transparency about it, suddenly it became a big deal. And so we would say, look, if it is going to be a big deal, share it and get ahead of the game if you can. Otherwise, being honest and transparent about, hey, we're using a range of models and these are the specific things that we're looking for is a much better way to approach that challenge. Okay, so let me pause there. Last thought, then we'll take questions. So how can we help at DataContours? Would love to, obviously we're steeped in this stuff. If there's anything that we can do, please reach out. Specifically, we can do regional and local forecasts. So if you're looking for information below the state level or even within a county, we can do forecasts and projections for what COVID outbreaks are likely to be, or what the 30 to 90 day outlook is. We can also do regional perspectives. So if you're looking at multiple counties or counties that fall across state lines where it's not easy to aggregate that data, that's kind of our sweet spot. So also happy to help support analysis or comm strategy or recommendations. So again, feel free to reach out. We also have local COVID forecasts for about 30 cities that we do every day for free up at the URL. Again, we'll send the slides out here to everybody at the end. So happy to jump over and talk about some questions. All right. So a question about materials. Again, we'll send out the slides and a recording of this right after. So you'll get all the materials, and we'll have sources for the data in there as well. And then somebody had a question about slide number. So the early and often, I think, was the slide I wanted to come back to. So in thinking about communication, doing it early and often, and you do this to address uncertainty. So in a vacuum of information, it's going to get filled in. So you want to be the one who's filling that in. And people are looking for that narrative. So rather than just putting numbers out there, provide the explanation, the what does it mean, the interpretation for folks. Because if you're just putting numbers out there, somebody else is going to provide that interpretation, and it may not be consistent with what it is you're making decisions based on. And then really would emphasize imperfect data is better than no data. So there is no perfect data. And so trying to find perfect data or wait for perfect data is going to be an impossible task. So go ahead and bite the bullet, acknowledge it's imperfect, be clear and transparent about why and how what you're doing to improve it. But definitely get it out there. All right, so what are the best ways to help organization leaders be more comfortable in releasing data and responding to modeling? Ooh, that's a good question. So I think there are a couple of ways you can approach it. Some best practices and examples I think are really helpful. I always look at what New York did, what Governor Cuomo did in New York as a great example of early and often and being transparent. And I think the way that he was able to manage the narrative is a really important takeaway, and do it in a very positive way. I mean, I think some of the results we saw out of New York were largely because the government, with him at the head, was so good at being transparent and providing the interpretation and crafting the narrative. So as you're working with your local leaders, I think helping them understand, look, this is a successful approach that's worked elsewhere. And you can also take the other side of it, which is, here are the communities that haven't done this, and here's some of the challenges they've run into when things got leaked to the press, or when they put out numbers that were not consistent with their decision-making criteria. Okay, so are there strategies for public resistance measures, no matter what the benchmarks have been hit? So the whole, I won't wear a mask, or I'm going out to the pool or the gym. Yeah, this is a really good one. And this is tough. I guess, our theory would be, this is a response to people not feeling like they can trust the narrative or the data that's being put out there. So it's a really hard situation to break out of. And a lot of times I think the challenge is you sort of start to get that feedback, and the reaction is, well, we'll just do less of it because it's not making a difference. Instead, we would say, lean into it, do more of it. The question about, acknowledge, look, one size fits all approaches are less than ideal. And we started doing this in March because we didn't know anything. We know a lot more now. And so if you can get targeted in those interventions, rather than saying, we're going to shut down all businesses, or we're going to require everybody to wear a mask all the time, trying to get it focused based on the particulars of the characteristics of the infections in your community, and start there and say, look, we're seeing infections amongst people who are 60 to 70 within this part of the county. And we think they're largely getting it from community spread. It is really important that people wear masks within grocery stores, because that's likely where these folks are getting infected. Something like that, a narrative that starts to get much more specific about the why and the what, can be a really helpful way to help those folks. And you're not going to reach everybody, and you're not going to convince everybody, but it can be a really important countermeasure to that broad feeling of, either overwhelmed by the information or not trusting the very simplistic general numbers that are being put out there. All right, any other thoughts or questions? Give people a few minutes here to enter anything in if you've got it. Okay, well, really appreciate everybody taking the time. Hopefully this has been helpful. We will probably do another one of these here in the next month, given how quickly things are moving. So, would love any feedback or thoughts or additional questions. Again, we'll after this, you'll get a recording. We'll send around the slides, and then happy to answer any follow-up. If you've got it, feel free to reach out. So thank you, everybody, and hope you have a good afternoon.